Hi and welcome to this educational video brought to you by the Society of Mechanical Ventilation. Volume Controlled Ventilation.
Hi, today we'll talk about a very familiar mode, the volume controlled mode. We'll define the mode, some of its clinical applications, settings, and important points. Of course, we all know that mode is the most common used mode, so hopefully it's not going to be too long. So when we define that mode, the problem, like any other mode, is the naming of the modes in different ventilators. So some ventilators call it AC, some call it CMV, some call it VC, AC, VC, which I really do not like this. The mode, according to Shadburn's classification, is the control variable is volume, so it's volume controlled, continuous mandatory ventilation. So basically the breaths are delivered based on set variables set by the clinician. The ventilator, the breaths could be either triggered by the patient or time triggered by the machine, and the ventilator is set to deliver a breath according to the parameters selected by the operator. The limit of the breath is usually pressure and cycles from inspiration to expiration, either by flow or now sometimes by time in some other ventilators. And we'll talk about this in the video. So when we set the settings of the volume controlled ventilation, we usually set tidal volume, respiratory rate, the minimum respiratory rate if the patient is passive. Of course, if the patient is active and breathing above the set rate, it will give him the rate that the patient can trigger. The flow waveforms, and the most common ones are either the square or the ramp. I'll show this again in the video. The peak inspiratory flow, and some ventilators you have to pick the peak inspiratory flow. Some other ventilators you pick the inspiratory to expiratory ratio. How the trigger, how the patient trigger the breath, and of course the PEEP and the FI2. So if we look at this picture here, it's from Puritan Bennett ventilator, and you can see here the respiratory rate, the tidal volume, the flow max, which is the peak inspiratory flow, the sensitivity, so this patient's flow trigger with sensitivity of 3 liters per minute, the FI2, the PEEP, if you want to put a pause during the inspiration, and the waveform, so it could be the ramp or the descending flow. Or if you look at the other example here, this is from the Hamilton G5. Again, the respiratory rate, tidal volume, the PEEP, the FiO2. Instead of flow max like here, you pick the inspiratory to expiratory ratio, and then the flow, the peak flow might be variable. If you want to put a pause for the plateau pressure, again the trigger, whether flow or pressure, and here's set at 5 liters, and the flow pattern, and this here we're using the constant or the square waveform. So again, most of the ventilators fall into one of either those two categories, and of course you have to know your ventilator. So this slide is very important, and it describes the difference between the volume control using the square flow waveform and the volume control using the ramp or the descending flow waveform. And the top here is the pressure, the flow, and the volume. And as you can see, the flow here is the constant or the square, and here's the ramp one. Now the airway pressure, as you can see, look different. This is again in a passive patient. So in the square flow waveform, it looks like a triangle here. And if you look at this green part, this is any breath to be delivered has to overcome mostly two forces, the resistance and the elastance. So in the square flow waveform, it looks like a triangle, and the top part here in the beginning of the breath is usually to overcome the resistance, and that blue part here is the remaining of the airway pressure is to cover the elastance, and elastance is 1 over compliance. And again, the tidal volume looks like this. Now let's go to the ramp flow waveform. Again, it looks descending like this. And if you look at the airway pressure here compared to this, of course, you can see the difference a little bit, almost like a rectangle or a square. And again, the beginning of the breath to overcome the resistance, and the rest as the flow coming down, that's to overcome the elastance, and the tidal volume looks a little bit different. So it's important again to know the difference between what waveform of the flow waveforms you're using, because that will alter the airway pressure. It's not going to alter the tidal volume because the tidal volume is set by the operator here. Now there's a lot of discussion about which one is better. Should I use the square waveform or the flow waveform? Some of the maybe the square flow waveform, you can dial usually the flow. So if you can see here, it uses a little bit less flow. Now there's a lot of research about how the peak inspiratory flow could be injurious to the lung. Versus here, you can notice here that it uses a little bit higher flow. This might be more comfortable to the patient versus this. So of course you have to try and see which one you're more familiar with and you want to use. Okay, this is a similar slide like the one that we just talked about, but also shows a little bit the effect of the equation of motion here if you look at it. So basically, for the breath to be delivered, you need the work of the ventilator, the work of the patient if he's active, and to overcome the compliance and the resistance. So if you look, this is the constant flow, and this how the airway pressure looks like in the black line. Looks like a triangle as we talked about. And this part in the beginning, as we talked in the last slide, is the resistance. So if the resistance is high, you get all the shape changes a little bit. It increases in that green line, dotted line. If the compliance worsen, you get changed a little bit of the airway pressure, you add this blue line. If the patient has muscle is active and actively breathing, you would notice again that the shape is altered a little bit concave, and I'll show you that in the video. Now we're gonna use the ramp flow, the descending one, and as we said, the airway pressure looks a little bit like a triangle. So if the resistance, which is usually in the beginning of the breath and the pressure, if the resistance worsens, you're gonna get that shape in the green dotted line. And if the compliance worsens, you're gonna get that shape like this. So you can see the difference. Just by looking at the airway pressure, you might get a hint this is a bad resistance or a bad compliance. And if the patient is pulling hard during their breath, again, you're gonna get that dip in the airway pressure. Okay, we'll start setting our volume control ventilation. This is again online simulator by Hamilton, and this is the G5 ventilator. And if you notice here, when you go to the modes, it's called S continuous mandatory ventilation. As we talked before, each ventilator called it something different, so you have to be careful. So we'll pick the mode, we'll do confirm, and we'll go to the settings. Of course, here's the respiratory rate, the tidal volume desired, the PEEP, the FiO2 level, the trigger, and you can make the trigger flow or pressure. This is if you want to put a pause, and we'll show this. And This ventilator uses the I to E ratio. Some other ventilators will use the peak inspiratory flow and the flow waveform. And the most common waveforms for volume control ventilation is the square or the constant flow. This is the sine flow, really nobody use it, or the ramp or the descending flow. So let's start with the square flow, the constant, and this is a patient with normal respiratory mechanics. You see the compliance is about 64, resistance is about 9, which is not too bad. Here's the airway pressure, looks like a triangle, and as we talked, the first part looks like resistance, effective resistance, and the end of the part is more of the elastance or the compliance of the respiratory system. And we'll see the changes once we adjust the compliance and the resistance. This is the flow in the pink, again in liters per minute, the airway pressure in centimeter water, and this is the tidal volume. Okay, so we'll try to put a pause to see again the effect of the resistance compliance. Usually you want to put an inspiratory pause, but that simulator does not have it, so we're just gonna put a pause with the during the inspiration. So if you look here, here's the peak inspiratory pressure, and the flow stops, so it drops to the plateau pressure, and the difference will be the effect of the resistance, which will be the tidal volume divided by the difference between the peak and the plateau pressure. And you can see the effect of the pause here and on the tidal volume. Now let's show it with a patient with a higher resistance. We'll increase the resistance to see the difference. Here the peak is 24 right now. I'm gonna increase the resistance to about 30, and of course you will notice that the peak inspiratory pressure will be very high. It went up to 52. The plateau is almost the same, and you can see that the effect on the flow. The expiratory flow will be very low, and again you can see the expiratory time constant is very, very, very slow. And if I increase the respiratory rate, you will see the effect of the auto peep that will happen because of the resistance is very high. So I think you can appreciate this. The ventilator will start to calculate the auto peep, but to calculate the auto peep, you need an expiratory pause. Okay, so let's go see the effect of compliance. So we're just gonna go back to the normal resistance, and we'll lower the compliance, for example, 20. And again, the peak inspiratory flow will increase, the peak inspiratory pressure, airway pressure will increase, but also notice that the plateau has increased. And the difference will be, again, if you calculate, the compliance here is 20 and the resistance is 9. And of course you can notice in the airway, the flow, expiratory flow, now the time constant became short, so the peak expiratory flow is very high, like here it looks like minus 120, and it collapses very quick. Okay, now we're just gonna put that patient again to normal compliance and resistance, and and the rate, and we'll go back to change the flow waveform, and we're gonna do the descending and try to appreciate. I'm just gonna remove the pause. Try to appreciate the difference now between the airway pressure. If you notice here, this looks like very similar to pressure controlled ventilation, because we know that pressure controlled ventilation use the decelerating waveform, so the airway pressure would look like a little bit like a square waveform here. Now let's go increase the resistance again. I'm gonna make it very high resistance, and of course the peak inspiratory flow will increase, not as much as on the constant or the square flow waveform. And let's put the pause again to see the difference. Again, you can see the peak is very high
the plateau is low, and you can calculate the expiratory resistance like we talked in previous videos. Now let's make again the resistance within normal and worsen the compliance back to about 20. And again, we'll notice that the peak inspiratory pressure will increase, but the plateau pressure here, you can see the difference is very minimum between the peak and the plateau. Again, the peak expiratory flow became very deep and very short time constant. The respiratory system wants to collapse. Okay, so I'm gonna go back to the constant flow waveform, remove the pause, and I want to show you the effect of the patient effort. This patient was a passive patient, meaning he's not triggering the ventilator, so he's getting exactly the rate, the tidal volume, everything that you said. So let's see what happens when the patient start to breathe normal. Sorry, not to have some inspiratory effort. So let's start with 5 centimeter effort. I'm gonna make that patient breathe about 20, so a little bit above our respiratory rate of 15. And I want you to notice the difference. You see, after it looks like a triangle, nice and straight. Now you see this concave dip here because this is the PMUS, or the muscle pressure of the patient. And of course the peak will be lower because the patient is now doing a lot of effort, and I'll show you the graph after that video what happens when the patient effort increase. You can see again he's triggering the vent. There is drop of the flow here that triggers the ventilator, and the more we increase the patient effort, here he's now breathing about the PMUS is 15, and look how deep the breath goes even to 0. So if you really measure the transpulmonary pressure, despite that the peak airway pressure or the plateau pressure will be low, this patient will have lung injury. So that's why one of the reasons I really do not like to use this mode. I don't have an esophageal balloon in this monitor to show you or to calculate it to you, but we talk about it in one of the other videos before. Let me put a pause because the ventilator, if you notice, does not alarm from this because the airway pressure is low, the patient is getting the tidal volume, so everything is good. But if you don't notice this, and I see it all the time, it's painful and it's dangerous, and you should be careful with this. So here, again, our plateau pressure is measured about 14, so it looks like everything is good on the ventilator. In reality, it's not. So the more the patient breathes harder, the more the airway pressure will dip negative, and I see that again that all the time, and it's painful. We should not have our patients doing this. I'll show you again the same when we change the flow. It might be a little bit better with the descending ramp. Let's remove the pause. Well, not really. Still, the airway pressure is dipping very hard, again because the patient is working too hard.
So, clinical application of volume control, of course, you can use it in any disease. Most of the studies, especially in the ARDS network, started by using the volume controlled mode. And as I said in the video, I really try not to use volume control. That's my bias. So I put that slide here. Should I use volume controlled mode or pressure controlled mode? And we'll talk about the pressure controlled mode in the next video. Again, this is a graph, the airway pressure in green, tidal volume, the flow difference between the constant flow and the volume control versus the decelerating one. And you can, with all honesty, you can achieve your goals with either mode. But if you notice here, there's a line here in the airway pressure. So pressure control usually give you higher mean airway pressure versus volume controlled. Well, of course, we all know the difference that mean airway pressure is correlated with oxygenation. and the reason is the area under the curve in pressure control is higher. So, of course, there's two schools of thoughts and some studies that didn't show any difference in mortality. But let's say the good and the bad about volume control. It's the same tidal volume every breath, which is, of course, our brain or neural pathways don't want that. Our breath is always variable with variable flow, variable tidal volume. Again, it's the same inspiratory flow every breath if you're using a set maximum flow or peak inspiratory flow. Again, that's not our natural breathing, and you're probably imprisoning the patient on the same tidal volume, same breath every breath. So of course, the patient, there will be a lot of dyssynchrony. The inspiratory pressure will vary, of course, as we talked about, with different changes in compliance, resistance, or the work of breathing of the patient. Of course, it's easy to set. Everybody wants to put the 6 milliliter per kg times the ideal body weight, so it's easy to dial a certain tidal volume. As we talked, it might not be very good or worsen the synchrony. It might worsen the patient work of breathing, and again, a little bit less oxygenation or inferior oxygenation because less mean airway pressure. For pressure control, it's the same inspiratory pressure every breath. The flow will be different, so that's a little bit better for the patient. The tidal volume, of course, will be different according to the respiratory mechanics, the compliance, the resistance, and the patient's work of breathing. I put here a little bit more difficult, but really it's not difficult. Again, you can adjust the tidal volume according by increasing or decreasing the pressure and the I time, and we'll talk about this next video. It can result in higher tidal volume, especially if the patient starts to actively breathe stronger. Tidal volume might go up. It's better in synchrony, better in oxygenation, and might reduce ventilator-induced lung injury, although again, those are unknowns, which one is better, especially for ventilator-induced lung injury. This is one of my favorite graphs, and I put it probably in a couple of other videos, and it just shows the interaction between the patient work of breathing during the breath and the ventilator work of breathing. So here from 0 to 100, meaning here the patient is passive, not doing any work, and here patient is doing a lot of work. So when the patient is passive, the ventilator always in any mode doing 100% of the work. So let's go to the volume control and the other adaptive pressure control, like the PRVC or adaptive pressure control. It has other names. When the patient is passive, again, the ventilator is doing all the work. There's no dyssynchrony. And the more the patient increases his work of breathing, matter of fact, what happens is the ventilator reduces its work of breathing. So if you have a patient in distress and respiratory failure and working hard, you will be actually doing him disfavor because he's still working very hard and the ventilator is not supporting him. It's actually reducing the support. If you look at the pressure controlled or the pressure support, here again, patient is passive, so the ventilator is doing all the work. And regardless what the patient work of breathing, the ventilator gives them the same amount of support. What will change is, of course, the tidal volume. So for me, this is better than this, although not very optimal. The optimal is for the ventilator to be adapting to the patient work of breathing. So if the patient starts breathing harder, the ventilator gives them more support. Yes, of course, the tidal volume will increase, but again, the patient is in a comfort zone. And of course, you can adjust your settings to keep the patient within the safe limits. And for those, usually the mode proportional assist ventilation and neuro assist ventilatory support, NAVA.